afternoon, everyone. Thanks for coming to our presentation today. I'm Louise. This is my colleague Emma Smith and Charlotte Bostock. Our talk is entitled Seconded Occupational Therapists into Primary Care. What's different and why social care OTs? And it's based on our own experience. So, the Royal College of Occupational Therapy have been advocating for OTs to be part of primary care. And across the country, occupational therapists have started working in newly developed roles within primary care networks. Here in Kent, the opportunity arose for 3 social care OTs to be seconded to primary care networks. The pilot was to be for a 3-year period to establish the occupational therapy role. Emma started first at the beginning of 2021, and Charlotte and I started later the same year. So you might be asking, what is a primary care network? So a PCN is a primary care network which consists of groups of GP practices that work together. They build on existing primary care services. These PCNs are designed to enable greater provision of client-centred and coordinated care for people close to their home. Each PCN serves approximately 30 to 50,000 people, so covering a lot of people in a area. Spread over a number of surgeries. So, for example, in our PCNs that we work with, we each work with between 4 and 7 GP surgeries in our PCNs. Over 99% of general practices are part of the PCN. They're led by a clinical director. That doesn't have to be a GP, it could just be a practicing clinician from one of the practices. Each individual PCN will have a variety of different team members. And across our 3 PCN teams, we have a variety of different people, such as business managers, social prescriber link workers, community pharmacists, mental health practitioners, physiotherapists. There's also multidisciplinary team and DT coordinators and enhanced care home teams, which may include paramedic practitioners, nurse practitioners, and care home MDT coordinators. So what were the aims of the project?
So the main aim of the project was to place the social care OT within the primary care networks locally and to provide a timely and responsive occupational therapy service. A lot of social care teams across the county have been experiencing waiting times, particularly after the pandemic, so this was the perfect opportunity for us to provide a much quicker service to clients in the area.
Would you be able to use the mic, just because it's getting noisy out?
No problem.
Thank you.
Try to break this song.
We also wanted to forge closer links between social care and our primary care colleagues to improve the communication between the 2 services and also improve the fact that it would make sense for us to be able to identify those clients who have long-term needs and needed supporting. And finally, it was to support care homes who don't always ask or know when to ask for support from social care. And all of the PCNs that we've been involved in have got dedicated care home teams. So it gives us quite a unique opportunity to provide moving and handling advice, seating advice, and help them to meet the occupational needs of their residents. So why social care OTs? Across the UK, primary care networks are employing occupational therapists, but they come from a variety of different backgrounds. There's mental health occupational therapists, OTs specialising in frailty, vocational rehab, and also physical rehab. But the Royal College of OT pinpoints a couple of key benefits from having OTs in primary care. Rapid crisis response, reducing hospital admissions and preventing hospital admissions, ensuring patients and carers continue to manage at home, telecare, digital technologies and proactive approaches to older adults. These are all really key skills that we have in social care, so it seemed like the perfect fit for us to be involved. Early on in the pilot, it was established that we really needed to make sure all the professionals within the primary care network had a really good understanding of what we could offer and provide their patients. We've got quite a diverse range of support that we could supply. So Emma began developing this tool really early on. It was an easy read document that we shared with all of our colleagues in the PCN to help guide them as to what we could offer, what kind of patients we would be able to see, and what interventions we'd be able to support them in.
So, what were the challenges we faced during our pilots? So, one of the main things was kind of understanding what OTs do, because quite often, even yesterday, I was explaining the difference between us and our physiotherapy colleagues, and how that differentiates across what we can offer. Also, it's about they need to understand the difference between us and our health colleagues, because we look at more long-term conditions, whereas community rehab teams look at short, sharp interventions to help people regain their abilities. So managing expectations was another one. They seemed to think that we could do anything for anybody, and that kind of went beyond our remit. So they thought we could complete wheelchair assessments, paediatric assessments, which would be lovely, but we are kind of restricted as to what our speciality is and our skill set is. Also, GPs use a task system, so the referral process got a bit clunky at parts through the way, because the rest of the PCN are employed directly by the PCNs themselves, whereas us three aren't. So for them to access us, they couldn't use the normal task system that they would use on their GP recording system, which is EMIS, just to kind of send it through and then the job's done. They still had to go through the whole correct process to get our input. Also, quality of referrals, they could be quite vague, kind of just a kind of client not managing at home. We didn't give you any more information other than that. So there was quite a lacking in information in order for us to be able to triage the most appropriate process for the referral to go down. Also, both social care and health use different IT systems. So it was we were duplicating a lot of our notes onto both systems and just looking at ways of trying to streamline this. So how we overcame the challenges. With regards to the knowledge of OT, we attended practice meetings so we could kind of educate them as to what we do. And we even used case studies to kind of demonstrate our input with some of the people they had referred to us. The diagram I designed was sent to practices for them to share with the practice staff, so that way they got an idea of what we could do, because we thought it was important to focus on what we could do rather than saying this is what we can't do. Also, we gave feedback on referrals to support patients, making sure they got the right support from the right professionals that they needed. With regards to managing expectations, again, by triaging referrals coming in, we can identify as soon as possible if the person was being sent to us incorrectly, so that way we can actually make sure they got part of the service for their support. And again, we attended the practices to educate them around our role. With regards to the referral process, by triaging the referrals, we can ensure there was a smooth process for the client's journey to follow, rather than keep going round and round in circles. We kind of make sure they got the right direction all the way. To support GPs and other professionals making the referrals, we organised for our social services professionals form to be actually embedded within their EMIS system, so that way, because quite a lot of the issue was how much time it was taking to complete the professionals form on our website, the EMIS system could pre-populate 90% of the form, so that way they had to literally write reason for referral. So we thought this might help instigate more referrals, because actually it was making it more user-friendly. We also attended community and care home MDT meetings, as Charlotte mentioned, because then we could provide guidance with regards to any potential input we could have, or if there was a particular route that patient's journey needs to take that they hadn't already established With regards to IT systems, our knowledge of the GP recording systems has grown, still growing, over time, and we found our own ways, each of us, to kind of reduce duplication of notes. So, also, part of what we did to help generate referrals, because in some of the areas there was a lacking in referrals coming through, we designed this poster to kind of prompt a conversation, because these could be put in waiting rooms, and anyone sitting there waiting to see a GP could identify with either an issue they were having or somebody they were caring for. So we thought that might just help prompt a conversation with one of the members of the GP surgery staff.
So what went well for us, or is still going well for us working in the PCN teams? The collaborative working has been the number one benefit I think we've all found, particularly working with social care prescribers who their main role is to support people to meet their social needs, so whether that be rehousing, attending appointments, managing finances, and a lot of those are issues that we come across day to day within our occupational therapy assessments and interventions, so mixing our functional assessment knowledge with those skills of the social care prescriber has worked really, really well, and seeing some really quick outcomes for patients. Direct access to the GPs, their medical note recording systems has also been really beneficial. It's meant that we've been able to access the information we need to provide quick interventions, particularly when it comes to housing adaptations where we're forward planning and future planning for patients' needs. Quite often, previously there was a bit of a delay waiting for that information to come through, but we've been able to get that and sort it really quick. The MDT meetings have provided ample opportunity for us to provide interventions and identify clients who are really complex. And it's also meant that we've been able to educate our colleagues in the voluntary sector as well through the case discussions in those meetings. Waiting times for all of us have been around about 2 to 3 weeks, so much quicker than previously. The feedback we've received from patients generally has been around the shorter waiting times, and we've considered that the early provision of minor equipment and adaptations could be having a long-term impact on the need for carers, reducing falls at home, and the chance to offer patients information and advice on how to deal with their changing needs as their disabilities may progress, may also contribute to reducing any crisis situations in the future.
So where are we now? Since the pilot began, we've received over 400 referrals across all 3 of the PCN areas we've been covering. Unfortunately, 2 out of the 3 roles are ending due to funding constraints, but 1 will remain ongoing because PCN have invested their own money into making sure it can carry on.
So reflecting on our experiences working within the PCNs, we can see that occupational therapists really have a potential to be a great asset. We've had some great feedback, and the benefits to patients and to the PCNs we feel has been great. It is the hope that other PCNs within Kent will consider utilising OTs as a way forward. But we have made really good professional contacts through our roles, and the hope is that we can continue to build on these relationships that we've developed. This will continue to enhance the patient experience, as Charlotte discussed, of health and social care services, and really promote a good client-centred experience. And if anyone is interested in additional reading, there is an article in the new edition of OT News about PCN OTs. There's some references, and any questions from anyone?
Is this an ongoing project?
Out of the 3 seconded posts at the moment, only 1 is ongoing. It's like a funding that 2 of them could continue. So the Shepway role is ongoing.
And it was ideally going to be for 3 years secondment, so there's like a 3-year period of time to try and establish the roles to see if we can kind of carry on.
Where are you now with that?
this one is 10 months in, the Expo one that's continuing has been going since September, so 10 months.
So the long-term vision is that we would maybe be more in the primary care setting. Presumably you'll get referrals that will communicate.
That's going to be one question. How does it sit alongside kind of normal PCC progress?
So we provide a social care assessment as we would do from the normal kind of community waiting list. But the referrals are coming directly from colleagues within the PCN, so usually it's more preventative measures rather than after people are already struggling.
Do you take professional referrals and do self-referrals?
The self-referrals generally would still go through social care, but if a patient was, for example, to have a GP appointment and happened to mention that they're struggling with the stairs or managing at home, the GP would then do that professional referral. It's been a lot of changing along the way, trying to streamline it and make it work.
Somewhere family got in touch with the GP and requested an OT assessment, and that's kind of instigated
Because
it.
otherwise you guys can find some absolutely innovative.
Oh, yeah. Arms, but they have to put our name for the area so it gets sent through directly to us.
Because we belong to social services, we still need to go through the processes of making sure we were kind of noting how many people were coming through, and also they've been going onto the waiting list as they would normally, but we've just been taking them straight back off and allocating them to ourselves to demonstrate the throughput and how much we're saving going onto the OT waiting list. I mean, personally, at the very beginning when we were waiting for referrals to come, we did take people off the OT waiting list, so that way we're kind of demonstrating our worth to the GP practices while we were waiting for referrals to come through. But I literally did that for the first month in where I was in the PCN, and then the rest of the time I think the throughput was enough, more than enough to keep me busy.
I think it's useful because it just demonstrates, it gives you the evidence base for putting OT in at the right place, isn't it? There's not enough resources to go around, we all know that. But so it's about repurposing that resource and sticking it where it's going to have the greatest impact. And for so much of occupational therapy work, especially from a social care perspective, it's about prevention, early intervention, and stopping things getting worse.
Stopping someone from deteriorating, because when they're sat on our OT waiting list, usually they're still declining how their condition's progressing. So
Those complex needs when this person does a bit and that person does a bit, and actually you can bring them all together and you all can see each other's systems, you actually know what everyone's trying and done.
Because we were helping also reduce how many people going onto our community rehab teams waiting list as well, I worked quite closely where I was with the physios and things, because by me seeing the person, it meant they weren't going onto their waiting list as well, but I could get the physio input that I needed at the same time. So it had benefits to not just the social care waiting list, it was kind of our community rehab.
Win-win all round.
Can we do a quiz?
So let's not carry on with it. Okay, any more questions? Yes, hi.
Hello. So I'm coming from a student perspective. So in terms of the roles, it sounds great, and you've done that in-reaching work. Have you thought about how you might be able to use the student placement within the PCN network to then continue that role, and you do sort of a long-arm supervision where you're not able to continue it?
I mean, I have had a student while I've been doing this role, and it worked really well because she was able, because she was one of our OT apprentices, she was able to kind of take it gave her scope to kind of spread her wings and kind of try a bit more of the complex stuff, but having that safety net, having somebody around should she need it. But yeah, she had her own caseload, working alongside me, which kind of shared the area between us. So it worked really well.
But in the future though, it would only work well if you did still have the OT, I think, in the PCN. I think it would be difficult to do it as a long arm because the OT wouldn't be employed.
And also you kind of need the GPs to keep having that education reiterated constantly as to kind of what we do.
Well, we'll see where we go when the project stopped and they go, oh, well, that's one of those OT people, wasn't it, that we needed. And we don't have one anymore. So we'll see what they do. Okay, thank you. Right, any more questions? No? Thank you, ladies. That's very, very nice.